Good afternoon.
Hi.
Hello. Can you hear me? Yeah.
Yes.
Oh, wow. It's true. You don't feel like you're talking all that loud, but the AV in this room is fantastic. Thank you again for joining us today for a special event that we're titling Understanding and Addressing the Unmet Needs of Women in the Sex Trade right here at Marquette University's Rainer Library. I want to start by giving a great thanks to Darwin and the library staff for really making this room possible and hooking us up with all of this amazing technology. A few housekeeping matters. Yay. Yeah. A few housekeeping matters. I want you to be aware that we are taping the presentation in two ways. One of the reasons why I'm standing behind this podium is because there's a camera that will be recording myself and the screen that we have presented. And then our communications intern, Abby, is also going to be taking some videos. I want to just remind people to silence their phone. And there's bathrooms out that way. We won't be taking a break, but I assume that you can find your way if you need it. So to introduce myself, I'm Jeanne Geraci, Executive Director of the Benedict Center. And the Benedict Center is Milwaukee's leading service and advocacy provider for women impacted by the criminal justice system. We provide gender-responsive, trauma-informed, harm reduction-based services for women, inclusive of cis, trans, and non-binary individuals. We provide an array of counseling and support services while helping women navigate out of the criminal justice system and the maze that it creates. We do this while advocating for system changes to promote social justice and health equity for everyone. Today's focus is around the work we do for women in the street-based sex trade, a marginalized part of our community that is highly victimized, stigmatized, and criminalized. Today's event features a research collaboration between the Benedict Center Sisters Program and Dr. Jessica Zemlak, an associate professor at the College of Nursing right here at Marquette University. The Benedict Center deeply values the community academic partnerships like the one we have built with Dr. Zemlak and Marquette University. We do because it helps us do our work better. We're able to leverage knowledge, research, evaluation, and other resources that wouldn't otherwise be accessible to a smaller community-based organization. These assets inform our work so that we can create best practices and demonstrate our impact. We also take pride in the contributions that we're making to advancing the work beyond our own local organization. That said, we're also selective about our research partners, and we need to ensure that our academic partners share the same key values and objectives that the Benedict Center does. Collaborative projects must directly advance the Benedict Center's mission and ability to serve or benefit women in pragmatic, on-the-ground ways. We also seek projects that are respectful of women with lived experience, treating them as experts and striving to conduct the work not only for, but with the participants. It is important to us that participants in our program regularly shape services and prioritize advocacy issues in formal and informal ways. You'll quickly see, if you don't know her already, why Dr. Zemlak is an ideal academic research partner for us. First, she's a nurse and a nurse practitioner, and she teaches nursing. Give me a profession that is more pragmatic and helpful and caring than nursing. Dr. Zemlak is also not just seeking information for the sake of it, but she really wants to put it to use and benefit in the real world. Dr. Zemlak already has a great deal of experience working with women in the street-based sex trade from her time in Baltimore and maybe also other areas. And she was generous when we first met and continues to be to share what she has learned and what she continues to learn, knowing that it's going to help advance our work. Dr. Zemlak also shares our values-based objective to meet the needs of women with a trauma-informed harm reduction framework. These frameworks are important because they provide an approach that honors women's agency and expertise with compassion, dignity, and respect. As a result, she approaches her work in partnership with women from our program, not just in partnership with the staff of our agency. However, our goal is to advance and improve the lives of women in the street-based sex trade. Even with our great academic partnership, we still need something else. We were intentional inviting you here today, people from different practices, different parts of our community, because the issues that face women in the street-based sex trade require a multidisciplinary approach to demonstrate. Let me ask by show of hands, who here is from the public health field? Thank you. Who here is from the criminal justice area? Thank you. Who here is from behavioral health services? You might be overlapping and raise your hand more than once. Thank you. Social services? All right. Advocacy organizations? Getting warmer, huh? Local government? Thank you. Academic? Students? How about caring community member? I hope all of our So you can see that we're really drawing on all different aspects of our community because that's what it's going to do. Our goal today is to share what we're learning and then to invite you to join or continue in broader conversation and collaboration that's going to lead to action. Actions that will move the needle on improving the health and safety for and with women in the street-based sex trade in compassionate, respectful, and effective ways. We're going to begin with an overview of the Benedict Center Sisters Program, and then we'll turn it over to Dr. Zemlak to present the findings or most salient findings perhaps of the research project. And then you'll hear from Carolyn, who's a Sisters Program participant and now works with Dr. Zemlak as a research consultant. She's going to share her insights into this work. And then I'll come back to briefly talk about next steps, and then we're going to open up for Q&A. And we left a sizable portion of today's time for Q&A because we really do want it to be an interactive conversation with you all. So first of all, I'd like to introduce Melinda Hughes, Director of Programs and Operations, and Gabby Johnson, who is our Sisters Program Manager, to provide an overview of our Sisters Program.
Good afternoon, everyone.
Good afternoon.
I'm Melinda. This is Gabby, and we're going to provide a brief overview. In terms of the Benedict Center programs, to kind of pull the lens out a little bit, the big picture is that there are 4 distinct programs within the Benedict Center, 3 of which are direct service programs, and 1 of them is focused on our community justice work and our systems change work. So I'll summarize some of that in the history, and then Gabby's going to talk you through some of the really specific services that Sisters Program provides. So at the top of the slide, we've got the Women's Harm Reduction Program, that substance use and mental health clinic. It's located on Martin Luther King Drive, and it provides outpatient services as you'd expect for a program, but with a lot of wraparound services involved as well, including employment classes and basic needs site as well. Our Women's Reentry Program as a Community Reintegration Center is another distinct program that had grew out of the Women's Harm Reduction Program. Our guests here there are guests here in the audience from the CRC. Thank you for coming. And it's a program, a satellite program within the CRC itself. So it's nice because we're able to refer clients from the CRC to outpatient services, including ours and other community agency programs as the client wishes. We also have our community justice program. And again, that's our advocacy arm and our systems change arm, trying to make each of the systems that interact with the women that we serve, be able to serve them a little bit better within those systems itself. And last, but certainly not least, we have our Sisters Program, which grew out of our outpatient clinic as well, with a forward-reaching arm, getting ahead of the contact, trying to reach women where they're at, out on the street, in the street-based sex trade. Jeanne kind of illuminated this to an extent, but the key element of our work in the Sisters Program and at the Benedict Center is that sense of respectful, non-judgmental, supportive engagement. We're trauma informed, strive to be culturally informed, gender responsive, evidence-based, all these sort of phrases and buzzwords all in one spot. But we really are trying to embody all of these principles and values in our day-to-day work, meeting the clients where they're at and making sure that the types of services that we're offering are supported by research and also client feedback and recommendation. Brief history of the Sisters Program. Started in 2011 on the north side of Milwaukee. Some volunteer space or donated space, if I remember correctly, and an initial outreach team. So we hear about outreach services as a key backbone of our work. We had a pre-arrest diversion pilot between 2012 and 2014, and wherein 70% of women completed their diversion agreements, and at the time, 19% left the sex trade work. In 2017, our Sisters South Faith Collaborative, some of whom are in the house today, thank you for coming, expanded the program to open the Sisters South Drop-In Center within Hope House. We're a tenant of Hope House, and that's at Second Orchard. And then, of course, the pandemic scrambled a lot of things, but our outreach team was only out of service for, I think, a couple of weeks. Mainly to get trained and outfitted to be able to do that work safely. They were essential workers during the pandemic, and then our drop-in centers reopened first in June. The South Drop-In Center opened, and then the north side, we were able to open a temporary home, and then finally a more permanent home at the Innovation and Wellness Commons, which was being built. So we were excited to be able to move in 2021 at 16th and North Avenue.
So I will be going over kind of getting you guys to understand how everything works for the sister program. So essentially where we first start out is through outreach. Outreach is that initial contact. So we are big with harm reduction and meeting them where they are. So with our outreach team, we are going between the north side and the south side of Milwaukee, where it is very known with sex work occurring. So essentially really meeting the ladies where they are, providing them those quick hospitality services, such as food, any kind of quick crisis needs in that moment. We did add on what's called the needle exchange program, where we are providing syringes supplies, as well as providing Narcan and fentanyl testing strips, where we also get them to learn about our drop-in centers when there is more needs than that can be met right then and there on outreach, where we will make the connection with either if they're on the south side, our south side location is on 2nd and Orchard inside the Hope House, or if we make any connections on the north side, we will take them to our north side location, which is located on 16th and North Avenue, where then we kind of really amp up and get them to understand the different services and more direct services that they can get in our drop-in center with our case managers and counselors on scene, as well as continuing kind of getting that hospitality service if they need somewhere to kind of shower, sleep, because we are dealing with women who are homeless. We also understand housing is a big need. So really helping ladies with getting into shelters, kind of providing them with any resources that we can provide for them. This is just some data of the Sisters Program from April to June to kind of give you an idea of exactly how impactful our work is with the ladies. So our outreach specialists have reached 467 unique women, which in that we have made 163 contacts. So that is us going out. My outreach team, which is a team of 2, they go out Monday through Friday between the south side and the north side of Milwaukee. On outreach, as I stated, we do provide meals, which we have made partnerships with the Gathering and Just One Touch Ministry. So we are able to provide hot and cold lunches for the ladies, as well as snacks. Then within the drop-in centers, because we love making contact with them on outreach, but our main goal is getting them to the drop-in center where they can get that more one-on-one services. We have touched more than 300 320 unique women. Within our drop-in centers, I told you that they can get more of those one-on-one assistance. So we do have an area we kind of run like a day shelter so they can sleep. We've had 114 women be able to sleep during the time that our drop-in centers are open. We're really big as far as clothing. Ladies are able to come and get change of clothing. We have been able to give out 723 items of clothing to women and within our drop-in center. Meals are very big. In the drop-in center, we've given out 868 meals. So even just like on outreach in the drop-in centers, they are able to receive food there as well. Even more so, because I did state that we have case managers and counselors, our women are able to get that more in-depth healing services, which 74 women have participated in that. And as of right now, we currently have 14 women working within the housing approach. So like I stated, we do starting with shelters, as well as when we learn of different opportunities, we will connect our women who do qualify to those. So as of right now, we do have 14 women within the DV, so that's domestic violence HUD grant. We were able to get 14 of our women housed through that voucher. We have 12 moved in and 2 are currently looking for apartments with the case management helps. Program 6 leads to additional funding and 7 extra rapid rehousing vouchers. So since we have done such a great job, we were given the opportunity of getting 7 more vouchers for our ladies because pretty much my team, as well as Women Harms Reduction, we've done a great job as far as making that connection with the ladies, finding out what their needs are, actually listening to them, and really helping them get back on the ball that they may have kind of fell off of and getting that assistance. So this is our healing service data for April through June. Through case management, 74 women were engaged on focused case management services. So with this is when we're making those straight referrals. So if we have someone who needs mental health services, the housing services, if they need services as far as medical, kind of anything that they need assistance with, we will help make referrals. As far as personal advocacy, so that is us helping be that voice for them sometimes, because sometimes our ladies aren't heard or they're judged. So having someone to be that assistance for you, that is what my team of case manager and counselors are there for our women. Transportation, like I stated, we meet them where they're at. So in a sense, we are definitely helping with transportation, because sometimes we will hear, oh, I would like to go there, but I don't know how I'll get there. So we are very big with, well, we'll help you there, as well as providing transportation such as bus tickets. Of course, with this type of work, you deal with crisis intervention, especially on the outreach lens of things. You are sometimes rolling up right into crises that you have to be kind of quick on your feet and really help the ladies with. So that's us calling crisis mobile for them, or just kind of seeing what we can do in this moment to help them be safe. And actually, within all of this, when I told you as far as us helping with housing and different things of that nature, we have helped 20 women relocate, and that is getting them into a shelter, housing. If they actually wanted to go into treatment out of state, we have helped women relocate. Currently, we have 19 women in counseling session. I think the one big thing that I love about our program is we are voluntary based. So we, again, continue to put that choice in our clients' hands and letting them know that they are the ones making the decisions for themselves. Our harm reduction activities include condoms distribution. During this quarter, we have given out 9,000 condoms. with the Narcan distribution, we have given out 13 this quarter, but that is something that has been extremely growing due to the fact of the education from my outreach team and as well as the ladies learning how very vital having Narcan on hand to help with an overdose episode has really been. As far as the clean needle kits, we've given out 7,190 kits this quarter. I will say that working on outreach, this has really been something that we have been learning more education on and understanding the need for, which we are now happy to be able to be a site for the ladies to comfortably be able to come get the items that are of need, as well as with clients receiving HIV testing. We have tested 17 women. Now with our testing, we have a unique way of it. We have it at our drop-in centers as well as we now provide it on outreach. So when we are meeting the ladies where we are bringing testing services to them. I will tell you at first, our ladies were kind of against it, but now that they see the trust with our outreach team, that has picked up tremendously for a lot of our ladies being able to get that quick in the moment service.
Awesome. Thank you. There's a lot to cover in a short amount of time, but that hopefully gives a good context of the program services themselves. And without further ado, we'll turn it over to Jessica. Thanks so much.
Well, hello, nice to see you all. Thank you for joining us. I'll tell you what, as a community engaged researcher, this is probably the biggest treat to be able to speak to people in a really practical way about my research. This is why we do this kind of work. So thank you so much for being here and hearing this. Just a little bit of orientation of what you can expect over the next 20 or 25 minutes. I'm going to talk you through a bit of background. Why did we need this research? What do we know? What gaps were we hoping to fill? How did we do it? What did we find? What were our results? And what does it all mean? Just a little plug, this data is going to be used for presentations and publications. So I just ask that you don't share slide data. So thank you for that. So a little bit of background of why this research was needed. So there is some research that's been done in other parts of the country, specifically in the Mid-Atlantic region, Baltimore, in Florida near Miami, and at the US-Mexico border, but we don't know a lot about stuff in this part of the country. So I'm going to share a little bit about what we know from other parts of the country and a little bit about how we organize this work. So we know that women in the street-based sex trade experience health disparities, things like increased risk for HIV, increased risk for violence. Organizing ourselves in terms of research, we often use something called a theoretical framework. And what that does is help us organize how we look at things. Theories help us understand behavior. So for this study, we use something called the syndemics framework. It's a big fancy word, but basically what it means is looking at overlapping risk factors for poor health. So for example, we know that if someone experiences intimate partner violence, that increases risk for HIV. When someone experiences intimate partner violence and substance use, that risk is higher. So what this organization framework, this syndemics framework does, it helps us understand how overlapping risk factors that women experience can drive health disparities. And this research was really driven by, I'm a Milwaukee native. I moved back here and I know this literature in this area, and there's just not a lot from our area. So there's a real gap in understanding. There's regional differences. So we really wanted to understand what the health and well-being was for women in our community. This slide shows what we know from other researchers. So other researchers, and this is specifically looking at the Mid-Atlantic region, Baltimore. Baltimore is considered a sister city to Milwaukee. There's a lot of similarities. So sharing data from that part of the country is helpful in understanding what we know that in a city that will be somewhat similar to ours. And this is organized using that syndemics framework, that same organization. So other researchers have found a lot of violence for women in the street-based sex trade. We have an epidemic of intimate partner violence in the United States. 25 to 30% of women experience violence. For women in the street-based sex trade, that number is much higher, 70% or more. This is what previous research has found. Part of the reason for that is there are multiple perpetrators of violence. So there can be clients or dates, intimate partners like husbands, wives, other people in people's lives. So violence on different fronts. We also know that women experience health disparities related to mental health. Other researchers have found PTSD, post-traumatic stress disorder rates to be higher or as high as combat tour US veterans for women in street-based sex trade, and extremely high rates of depression. So in the US general population, rates of depression are like 9 to 10%. For women in the street-based sex trade, other researchers have found that to be 80% or higher. When we think about substance use can be a reason people enter the sex trade. It can also be a reason people stay related to consequences of trauma. And we know that has health implications. For example, it can increase risk for HIV. Other researchers in Baltimore found 80% of women in street-based sex trade use opioids or other pain relief. And finally, we know there are social and structural vulnerabilities that women can face. For example, experiencing homelessness and food insecurity. Interestingly, other researchers have found that most women have health insurance. So this is what we found in other research. And now we'll talk a little bit more about what we found here in our community. So this just outlines what we hope to achieve with this research. First, we wanted to look at and understand the overall health and unmet health needs of women in the sex trade here in our community in Milwaukee. We wanted to use that syndemics framework to understand risk factors for poor health. And finally, we wanted to hear from women themselves. So we did focus groups to hear from women and understand more about what we found in our surveys. So I'm going to talk a little bit about how did we do this research? How did we do it? Who was in it? What was the study design and what were our methods? So first and foremost, who was eligible to participate? Who did we recruit to participate in this study? We had two components of the study. The eligibility was the same for both. So people had to be an adult, 18 or older, attend one of the sisters drop-in center sites, so on the north or south side. They had to be able to provide verbal consent that they would participate. And then they had to indicate that they sold or traded sex for something of value, food, drugs, money, shelter, at least once in the previous 3 months. So how did we get this information? So this study was designed, it's called an explanatory sequential mixed methods design. And what that mouthful means is that we really got data at 2 different time points. So first we did a survey. And you all have probably done surveys like this where you fill out things on an iPad where there's questions and you tap an answer. So this was designed much in the same way. We had fixed choice survey questions that were used from tools that have been used by other researchers validated in our population and some descriptive information. What we did was we had research assistants read women the questions and input them in the iPad. The rationale being we didn't want literacy to be a barrier for participating in our study. So then we had this data, number data, we analyzed that data and looked at it, shared it with the sisters team, and we needed more information. We needed to understand this more deeply from the voices of women. So the next step was focus groups. And basically what that means is small group interviews. And we did that between November and January. And in this, we shared the results of our study using a semi-structured interview guide. So we had a little bit of interview questions and we talked to women and got their impressions to understand those numbers a little more deeply. This is a little summary of who participated. So in our survey, that first step, we had 52 participants and they were from both the North and South Drop-In Center. On average, they were about 38 years old. Most identified as cisgender women and nearly 70% identified their race as Black African American. In our focus groups, we had a total of 6 groups. Over those groups, we had 25 participants. The average age was 43, most were cisgender women, and again, 69% identified their race as Black African American. So what did we learn? I'm going to walk you through some of the more salient results. This isn't all the data we have, but this is just some of the more pertinent results for this group that we found. You'll see for the survey, those are presented like statistics, so numbers and percents. And then the focus group data is quotes from women's voices. We didn't collect any identifying information from our participants, so there's no names or identifying information included, so you won't see any of those sorts of details there. So first, talking about healthcare utilization. Our participants, just like the ones in Baltimore, almost everyone had health insurance. So 90% of women identified as having health insurance. Most common insurer was Medicaid. A little more than half of women had a primary care provider. Fewer women had a mental health provider. And even fewer women had a dentist. Dentist is a huge unmet health need for the women in our population. The emergency department is a safety net service for many people in our community, and the women in our study are the same. There was a big range in how often folks go to the emergency department. It was between 1 and 40 times per year. but there were a couple outliers on either side. I know it's a lot of emergency department, but most people were in for a few visits per year. And this is sort of straddling the pandemic times as well. So it may be a little skewed related to sort of being in that early post acute COVID time. We wanted to know what the health problems that women were facing were. So we created a list of the most common health conditions which people go to the doctor for. And women were able to select all that apply of which conditions applied to them. So you can see these are the common conditions that folks had that participated in our study. What is a little bit unique for the people who participated in our studies, nearly half of our participants increased their alcohol or drug use to cope with medical symptoms. And this is a real call to action because we have a world in which our drug supplies are incredibly tainted with things like fentanyl, down the pipeline, things like xylazine and tranq. So this increases the risk and introduces a risk of worse health outcomes that people maybe didn't think that were going to happen. So things like overdose and death. So people are using drugs and alcohol to cope with medical problems. You remember we started by talking about the prevalence of violence. So we did ask our participants about violence, physical and sexual violence. We asked about violence over their lifetime and also in the past year. This is past year experiences of violence. So in the past year, 76% have experienced date or client physical violence. This includes hitting, punching, choking, or use of a weapon. That is a tremendous amount of violence. 43% experienced forced or pressured sex by a client in the past year. And unfortunately, this violence isn't just in sex trade. It is also outside of sex trade with regular partners like boyfriends, husbands, wives. Half of women in the past year have experienced hitting, punching, choking, use of a weapon by a regular partner. And 21% experienced forced or pressured sex in the past year. So these are just really important to think about because of the consequences that come with this much violence. The physical consequences like injury, the mental consequences from trauma, but also when we think about for those of us who work in sexual and reproductive health, how this might influence your ability to have autonomous control over things like HIV prevention, health promotion with condoms. Just something to think about. The implications of physical and sexual violence are really affect a lot of different domains of women's lives. And we asked about violence and talked about violence in our focus groups. And it was really pervasive in women's lives within the sex trade and outside of the sex trade. The first participant said, I got in the car, a date, pulled a gun on me, but I'm a fighter. I'm not about to die. Every car I get in, I'm scared. Before you know it, you're raped, robbed, pistol whipped, you name it. It's really scary getting into a car with someone you don't know. Violence was really pervasive. It was in women's lives, in the sex trade and outside of the sex trade. We did ask about human trafficking in our survey and also in our focus groups. And when we asked about human trafficking, we really tried to align our questions with what the Department of Justice considers aligning with trafficking. So we asked about commercial sex work under the age of 18. So 33% of our women sold, and this is lifetime experiences. So this may not be going on right now, but in their lifetime, 33% of women sold or traded sex when they were 17 years or younger. To get at the idea of force, fraud, or coercion for our adult participants, which is the criteria of considering to be trafficked, there isn't a great instrument to measure this in research or in community populations. Other researchers have tried to assess this idea of force, fraud, or coercion. We use the 6 items on this list to assess for engaging in commercial sex work related to force, fraud, or coercion. 85% of our participants said yes to at least one of these. So in their lifetime, 85% of our participants were engaging in the sex trade, not voluntarily, but because of force, fraud, or coercion. And we talked about this in focus groups. So this was something women spoke about, seeing people being trafficked out on the street and experiencing themselves when they were children. For example, the first participant said, human trafficking is real. I was 13 when I got into this. I chose a pimp. I started hustling at 12. Back then you had to have a pimp. Others described experiencing trafficking as an adult. And most often that was in the context of having a pimp. I had a gorilla pimp, someone who forces you to sell sex or go through them for drugs through force, like a gorilla. Pimps, they want that money. They want your whole life. Either you get along, you get beat up, and you get killed. So for women, trafficking experiences included childhood experiences, but it also included commercial sex trade experiences as an adult with pimps. Mental health is a priority, and we asked about this in our survey as well as in our focus groups. So we used validated instruments to assess for symptoms of PTSD. A shocking 71% of women in our study had symptoms of PTSD, and this is higher than they found in other research studies. So our rates of PTSD are a bit higher. 62% of women had moderate to severe depression. So we used a validated instrument, some of you may be familiar with, the PHQ-9, to ask about depression. And we used a clinically significant cut point for that. And 62% of women have moderate to severe depression. And then we asked about, have you ever been diagnosed by a clinician with a mental health disorder? And nearly 80% of women indicated they had. And again, 50% of women are increasing alcohol and drug use to cope with mental health symptoms. So similar to medical problems, for mental health symptoms, women are increasing alcohol and drug use. In our survey, we provided a list of those common health complaints that we said, what's your number one? What's your top priority? And 65% of women rated mental health as their top concern. In focus groups, women said, I need mental health. Mental health is number one. Oftentimes, women spoke about mental health and linking it to trauma in their lives. I'm starting to realize that my childhood had a deep toll on me now because I'm a messed up individual with mental health. So mental health was a priority. Women recognized the challenges they faced with regards to mental health symptoms. And in our survey, we asked about substance use. 98%, so the vast majority of women who did our survey have used drugs in the past year. When we asked about lifetime experiences of drug use, there was a range in age of when people first started using drugs, but the average age was about 17. Heavy alcohol use, oftentimes researchers are surprised that alcohol lifts up to the top of the pile in terms of things that cause health problems and challenges for women. Heavy alcohol use was pretty common in our sample. 25% of women were having 10 or more drinks a day. We asked women in the past year, which drugs have you used? They could select all that apply. So women could obviously use more than one. The most common drug used across all of our study participants was cocaine. And people used, you can see on the list here, all of the different drugs people used. And when we talked about drug use in our focus groups, women often spoke about the complexity of drug use in their lives. Drugs were a way to cope. The drug was my best friend because it helped me escape. The thing is, drugs have always been my way of coping. It was also sometimes what caused women to feel the reason why they were engaged in the street-based sex trade. I've been using drugs since I was 17. That's the reason I'm out there. Cocaine is the worst pimp in the world. The only pimp I ever had was crack cocaine. So when women described drug use, it was often this complex and chronic experience in their lives. It was often identified as their way to cope. And we explored sexual and reproductive health in our survey. We asked women to self-identify their perceived HIV risk. So we said, what do you think your HIV risk is? And women were able to respond using a Likert scale. So that means 5 different response options from like no risk to very high risk. 40% of women who took our survey felt they are not at risk for HIV. 21% felt they were at small risk. So the vast majority of women who took our survey didn't identify themselves as being high risk for HIV. This is probably incongruent with what we as healthcare providers and those of us who work in the healthcare space or HIV prevention space might think. One of the most exciting tools in our toolbox is PrEP, which is a daily medicine you can take to prevent HIV. Less than half of women had ever even heard of PrEP, and they're excellent candidates for PrEP, an HIV prevention medication. We asked about how often people were going to get STI screening. Women were getting screened regularly. Most women have been screened this year. 25% reported having an STI in the past year. And then we asked about contraceptive use. What contraceptive methods are women using? Much like other research, we found condoms were the most common contraceptive method used. Condoms are great. They prevent STIs. They prevent unintended pregnancy. But the challenge with condoms is they have to be used with each sex act, right, to be effective. That can be tough to do in the context of high coital frequency, meaning having sex frequently. That can be hard to do when there's a lot of violence because it might not be safe to do that. So condoms are wonderful, but there are limitations. And when we talked about HIV risk and STI risk in the focus groups, just like in the survey, people's HIV perception of their risk was really varied. Some women felt it was high. I feel that my risk is bad. You don't know who you're dealing with. Others felt it was low because they do health promoting behaviors. My risk for HIV is low because I keep it that way. I use condoms, I don't use needles. Other women felt their risk was low because they get screened a lot. I'm low risk because I went to the doctor and I don't have anything. And we talked about PrEP in the focus groups. And again, similar to our survey, women didn't know much about it. And when they did, funny enough, they often learned about it from TV commercials. That's how they heard about it. So that was the most common way. But they were interested in learning more. I heard about PrEP. I want to hear more about it. And this participant was pretty funny. She said they need to pass those PrEP pills around and put them in our lunch bags. So there's interest. So this is our list of services. We asked women, what do you want at the drop-in center? What do you value? This was one where they could pick whatever they would, but all that they apply. So you'll see a lot of centered responses around medical stuff, mental health, telehealth, and substance use. And we talked about this in the focus groups. Women wanted groups. They wanted groups that focused on spirituality and trauma. They wanted more of what they receive at the Sisters Program. So they love what they receive. They want more hours. They also, I'm always amazed at how much women care about other women. In fact, when we were coding our data, that was actually a theme that we had. Women care about other women. And over again, women said, I wish we could get more women here. So they wanted more outreach. They want to help the women that are on the street that aren't coming into the drop-in center because they know the value of coming to the drop-in center. Also health. Women described sometimes the difficulty of accessing health, the challenges they face. So wanting more health services, maybe thinking about telehealth as a way to improve access. So what does this mean? I'm going to speak to what this means in terms of what it means for research and next research steps. So our next research step is really exciting. We're launching a teleprep study. So this is an HIV prevention study. We are going to have a telehealth kiosk, so a video kiosk within the Sisters North Drop-in Center that women can access, and they'll have a one-on-one visit with the HIV prevention specialist from the Medical College of Wisconsin. What we're doing here is trying to see, do women like getting care this way at the drop-in center? It's kind of novel to bring care, as Gabby said, bringing things to where women are. The other idea is, do you like this? Do you like getting care in this way in a video at the drop-in center? It's driven a little bit by, we all know that telehealth has exploded after the pandemic. I'm sure most of us in this room have engaged with the healthcare provider in some sort of electronic way. There's a growing concern for those of us who work among marginalized communities that people are going to get left behind. Telehealth isn't going away. The digital advancements aren't changing, and we have to engage folks in this process, or there's a real risk that inequities that we see are going to continue to grow. We also hope if women like getting care this way, maybe we can expand it to other things like mental health and other stuff, but we have to first see if this works. So that's what the purpose of this feasibility study is, to see if it works. And I wanted to close with some of the words that women said. We didn't ask for this. This was just peppered throughout our focus groups. And I pulled some of the most, I thought, moving quotes. Women really love the Sisters Program. So please don't close the center. We need more resources for this program. They do give us a lot of tools to survive. I think they give us a lot. So Sisters is truly a trusted resource for women. And finally, I want to close with acknowledgements and gratitude. First and foremost, I want to thank the people who participated in my study. I am incredibly grateful. I know the courage it takes to share your story so vulnerably and to do this, and it's often done with the intention of wanting to help other women. That is often what women say. I just want to make it better for someone else. So I'm grateful to them. I'm also so grateful to the leadership at the Sisters Program and the people that work at the Sisters Program. They were so supportive of this work and so helpful and cared so much about the work. And research is definitely a team sport. So I'm lucky to have collaborators, Dr. Stacey Young, who assisted with the focus groups, and my research assistants. They were the backbone of this work and amazing humans. Two of them are here today, Aaliyah Berry and Evelyn Gabriel. Thank you guys so much. And my consultants, the newest members of my team, who you're going to hear from shortly, Carolyn Winos and Ramona Shines. They have joined my research team as consultants because we want to have women with lived experience be with us and hear their voices and be part of this work. And finally, research costs money. So thank you, Marquette University Office of Research and Innovation, for funding this work. Thank you so much.